Welcome back to the deep dive.
Great to be here.
Today, we're jumping into something really quite fascinating in neurology, but also, maybe surprisingly, underfunded.
Ah, yes. Let me guess, IGE.
You got it. Idiopathic Generalized Epilepsies. I mean, the numbers are pretty striking. Maybe 1 in 5 epilepsy cases fall into this category.
That's a significant slice.
It really is. But, and this is the part that caught my eye, they apparently get less than 1% of the research funding.
Wow, less than 1%. Yeah, it's quite a gap.
So our kind of mission today is to, well, maybe clear up some common misunderstandings about IGE. We want to highlight what we do know, especially for, our listeners who have a medical background or just a really strong interest in neurology.
Sounds like a plan. Because you're right, when people think epilepsy, maybe focal epilepsies, the ones with a clear spot in the brain or symptomatic ones, often come up first. But IGE, this group is, well, fundamentally genetic. Historically, they were separated from those symptomatic ones, where you could see a lesion on a scan or something.
Right. Idiopathic meaning because unknown originally,
Right.
but now leaning more towards genetic.
Exactly. Though environment, stress, they play a part too. A really key thing early on was the EEG finding that bilateral symmetrical spike wave pattern across both sides of the brain.
The generalized spike wave discharge, or GSWD, usually around 2.5 to 6 hertz.
That's the one. And yeah, it's important to flag that the official terminology from the ILE, the International League Against Epilepsy, has shifted. They now prefer genetic generalized epilepsy over idiopathic. It reflects that growing understanding.
Okay, good point. So let's really unpack this for, say, the medical students or the neurology enthusiasts listening. Because while IG might sound straightforward on paper,
It often isn't.
right, our main source today, it's a 2023 article in Neurology by Davinsky and colleagues called Idiopathic Generalized Epilepsy: Misunderstandings, Challenges, and Opportunities.
Yeah.
It really paints a much more complex picture.
It certainly does, and I think that's where the real learning is, the aha moments, as you said, getting into those nuances.
So what's the first big misunderstanding the article tackles?
Well, probably the idea that diagnosis is always straightforward. See the GSWDs, see the generalized seizures like absence or myoclonic jerks, and boom, it's IGE.
It's not always that clear-cut.
Not at all, and this is super relevant for clinical training. Patients with IGE can actually show up with features that look asymmetric or even focal, both on their EEG and in how their seizures actually manifest.
Okay, hold on. Focal features in a generalized epilepsy. How does that work?
Yeah, it sounds counterintuitive, right? But think about a generalized tonic-clonic seizure, a GTCS. The article points out you might see the head or eyes turn strongly to one side initially.
Okay.
Or the limb movements might be noticeably stronger on one side than the other.
Which could easily make you think it started focally and then spread.
Exactly. Or even absence seizures, the little automatic movements, the eye blinking, they can seem more prominent on one side. Same for myoclonic jerks.
And the EEG can be tricky too.
Definitely. You might see that generalized spike wave activity, but it might look like it starts more intensely on one side just before it spreads everywhere.
Right. So if you only caught that very beginning bit.
You might misdiagnose it as focal epilepsy, which obviously has different treatment implications.
So how do you tell the difference? What are the clues pointing back to IGE, even with this asymmetry?
Okay, so the article gives some really good pointers here. First, that initial one-sided lead-in on the EEG and IGE. It's usually very brief, like less than 2 seconds.
Okay, short duration.
Second, the actual shape of the spikes, the morphology, it tends to be the same on both sides, like a mirror image, even if one side looks a bit stronger initially.
Okay. Symmetry in the shape, even if not in the amplitude right away.
Precisely. And crucially, you shouldn't find other signs that scream focal epilepsy. Things like independent spikes firing off just in one specific area, separate from the generalized bursts, or persistent slowing of the brainwaves in just one region. Or importantly, any actual neurological deficits on exam, like weakness on one side or reflex changes.
Got it. So if you see those things, the independent focal spikes, the focal slowing, the neurodeficits, then you should suspect it's maybe not IGE.
Then you should definitely think about secondary bilateral synchrony, a focal seizure that's just spreading really, really fast. And in that case, getting an MRI to look for an underlying structural cause is absolutely the next step.
Okay, so the big takeaway here: don't let a little bit of initial asymmetry fool you. Look at the whole picture: duration, spike shape, absence of other focal signs.
Exactly. Context is everything.
Right, so that's diagnosis. What about the underlying mechanics, the pathophysiology? there's another common idea that we pretty much got that figured out for IgE.
Yeah, that's another misconception the article tackles, and it's important for anyone studying this stuff. We do know that hypersynchronization within the thalamocortical network is key.
That big communication loop between the thalamus deep in the brain and the cortex on the surface.
Right, and we know genetic variations affecting things like calcium channels and GABA receptors, which are involved in brain signaling, play a big role.
But that's not the full story.
Apparently not. The article stresses that other mechanisms are likely involved too. Things like maybe increased levels of glutamate, an excitatory neurotransmitter in the thalamus, or decreased levels of something called N-acetyl aspartate, which is related to neuron health.
So more complex than just GABA and calcium channels.
Definitely. And another fascinating point is about the term generalized. It can be a bit misleading.
How so?
It doesn't literally mean every single neuron in the entire brain is firing together perfectly in sync during these events.
Ah, okay. So it's not like the whole brain just goes haywire uniformly.
Not quite. It seems to be more about specific circuits, primarily these thalamocortical pathways, becoming hypersynchronized, while other networks might be relatively okay. Think of it less like the entire power grid going down, and more like specific, crucial substations malfunctioning and causing widespread disruption through their connections.
That's a much clearer picture. It's widespread because of the networks involved, not because every cell is doing the same thing. What about imaging? Does MRI show anything in IgE? Traditionally, we thought scans were normal.
Right, that was the classic teaching, normal MRI. But more advanced imaging techniques are starting to show subtle differences.
Like what?
Things like maybe slight reductions in volume, a bit of atrophy in certain areas, particularly the frontocentral parts of the cortex.
Okay.
And functional imaging, looking at brain activity, also suggests abnormal function in those cortical areas, and maybe involvement of deeper structures too, like the basal ganglia or even the cerebellum.
Interesting. So even structurally and functionally, it's not quite as normal as we once thought.
Exactly. And there's another cool link the article touches on the connection between these IgE networks and our sleep-wake cycle.
Yeah. Many people with IgE have seizures at particular times of day, right? Like early morning.
Precisely. And the brain networks involved in IgE overlap significantly with those regulating sleep and wakefulness. This might explain those circadian patterns. And those bursts of fast spikes you sometimes see on EEG during sleep in IgE patients, they might actually be a marker for drug resistance in some cases.
Wow. Okay, so for our med students listening, the takeaway is IgE pathophysiology is way more intricate than the simple textbook explanation. Specific networks, multiple mechanisms, subtle imaging findings, links to sleep. It's a busy area of research.
Absolutely. It's evolving.
Let's shift to another common belief,
Yeah.
that seizures in IgE are, generally easy to control with medication.
Yeah. That's definitely not always the case. Many clinicians listening will have patients who challenge that idea daily.
So the article confirms this.
It does. It explicitly talks about the reality of chronic seizures and even drug-resistant seizures in IgE. This isn't just a childhood thing that always gets better. You can have adult-onset IgE too, which can be tough to treat.
And even if someone initially responds well,
Breakthrough seizures are a real concern, and importantly in IgE, those breakthrough seizures are often the big ones, the generalized tonic-clonic seizures.
would carry more risk.
Potentially, yes. More risk of injury and also contributing to the risk of suit-up, sudden unexpected death in epilepsy. Arguably, a sudden GTCS can be more dangerous than, say, a non-convulsive focal seizure.
That makes sense. So what helps prevent those breakthroughs?
Well, the article really hammers home the importance of medication adherence. Taking meds consistently is crucial. And lifestyle factors, getting enough sleep, avoiding excessive alcohol, these are huge, especially for teenagers or young adults who might be, testing boundaries.
Yeah, those factors are notoriously tricky in that age group.
They really are.
Okay, what about the idea that IgE is something people just grow out of? That's another one you hear a lot.
It is, and it's partly true, but also partly myth. Some childhood onset forms, especially childhood absence epilepsy, do often remit. Many kids stop having seizures and can eventually come off medication.
But not all IgEs.
No. A classic example is juvenile myoclonic epilepsy, JME, that often requires a lifelong treatment to stay seizure-free.
So it really depends on the specific syndrome within IgE.
Absolutely. And even when trying to stop meds, success depends on things like how old the person is when they try, how long they've been completely seizure-free beforehand, and if they needed multiple drugs to get control in the first place, especially true for JME, it's not a universal outgrowing its situation.
Good to clarify. Let's talk morbidity and mortality.
Mm.
The perception might be that IgE is relatively benign compared to some other epilepsies. Does the article agree?
Not really. That's another key point for anyone managing these patients long term. The article highlights that rates of things like anxiety, depression, even autism spectrum disorder.
The psychiatric and neurodevelopmental comorbidities.
Exactly. And also issues with executive function planning, organizing, working memory. These are actually pretty similar in IgE compared to focal epilepsies.
So the overall burden isn't necessarily lower.
It seems not. And tragically, the risk of SOGE, sudden death, also seems to be comparable between IgE and focal epilepsy, particularly linked to uncontrolled GTCS.
Wow. Okay. That really drives home the need for comprehensive care, not just counting seizures.
Precisely. Addressing mental health, cognition, quality of life, it's all crucial.
Okay, one last misconception before we move on.
Right.
The idea that surgery is basically impossible for IgE because it's generalized.
Right. You can't just cut out the epilepsy spot if it's seemingly everywhere. But the landscape is changing here.
How so? Not resective surgery, surely.
No, not typically cutting tissue out. But the article talks about the emerging role of neuromodulation for drug-resistant IgE.
Like brain stimulators.
Exactly. Things like vagus nerve stimulation, VNS, deep brain stimulation, DBS, targeting specific deep brain structures like the thalamic nuclei, the centromedian or anterior nuclei, also responsive neurostimulation, RNS, which detects seizure activity and zaps it. Even transcranial magnetic stimulation, TMS, is being explored.
Is the evidence strong for these yet?
The article notes it's mostly level D evidence, currently meaning open label studies, case series, that kind of thing. Not huge randomized controlled trials yet for most indications in IgE.
So, promising, but still early days.
Pretty much. But these studies do suggest potential benefits, reducing seizure frequency for some folks who haven't had luck with multiple medications. It's an option on the table now, alongside things like dietary therapy, ketogenic, or modified Atkins diets are also mentioned for drug-resistant cases.
That's really encouraging, actually, having more options when meds aren't enough.
Uh,
Okay, let's switch gears slightly and talk genetics. We said IgE is considered genetic, but the article calls it complex,
Very complex. It's typically polygenic.
meaning many genes involved.
Yes, likely many different genes, each contributing a small amount to the overall risk or susceptibility. It's not usually one single epilepsy gene.
Which explains why twin studies show higher rates in identical twins than fraternal, but it's not 100% even in identical twins.
Exactly. That points to both the strong genetic component and the role of other factors. Now, there are rare cases where a single gene mutation is the main cause, like GLUT1 deficiency syndrome or some mutations in GABA receptor genes, but these aren't typical IgE syndromes usually.
So for the average person with, say, JME or absence epilepsy, standard genetic testing isn't likely to find a single smoking gun.
Generally, no. That's why clinical gene panels or even whole exome sequencing often come back unrevealing in typical IgE. They aren't routinely recommended unless the clinical picture is unusual or suggests one of those rarer single gene causes.
But large research studies have found genetic links.
Oh, absolutely. Genome-wide association studies, GWAS, looking at huge populations, have identified quite a few DNA regions, dozens of loci, associated with an increased risk of IgE overall. So the genetic basis is definitely there. It's just spread out and complex at the individual level.
Okay, so if it's not just genes, what else is involved?
That's
You mentioned other factors. Environment, epigenetics.
Yes, these are getting much more attention. The fact that identical twins aren't always concordant, meaning one can have IgE and the other doesn't, despite identical genes, is strong evidence for non-genetic factors.
Like what kind of factors?
Well, epigenetics is a big one. These are changes that affect how genes are read or expressed without changing the DNA code itself. Things like DNA methylation. Studies have actually found different methylation patterns in discordant identical twins.
Fascinating. So the same gene might be turned up or turned down differently.
Potentially, yes. And then there are environmental factors, things like diet, the gut microbiome, the bacteria in our gut, maybe head injuries earlier in life, infections, immune system responses.
It's a whole mix.
It really is. Even things that provoke seizures acutely, like major sleep deprivation, alcohol withdrawal, maybe repeated exposure, could contribute to the development of epilepsy in someone already susceptible. It's complex interplay.
Genes load the gun, environment pulls the trigger kind of thing.
Perhaps, yeah. Or maybe environment primes the gun, too. It's still being worked out.
Right. This complexity also seems to bleed into how we classify these epilepsies. The article mentions challenges there too.
Oh, definitely. Classification is always evolving in epilepsy. The current system tries to categorize based on seizure onset generalized, focal, both, or unknown.
And then we have specific syndromes within those categories like childhood absence or JME for generalized epilepsies.
Right. But the article points out these nice, neat boxes can be a bit artificial sometimes. They might oversimplify what's really a spectrum. Well, there's a lot of overlap. Patients might have features that fit bits of different syndromes. The terminology has changed over the years, causing confusion. And you get these borderland cases, patients who just don't neatly fit any specific syndrome definition.
You give example.
Sure. The article uses the example of a kid who has that classic 3 Hz spike wave on their EEG, typical for absence epilepsy. But maybe they've only ever had one single generalized tonic-clonic seizure, no actual absence seizures yet.
So what do you call that? Is it IGE?
Yeah.
Which tree syndrome?
Exactly. It creates diagnostic uncertainty. And the article makes the big point that the EEG alone, even if it shows generalized discharges, can't always reliably differentiate between the specific IgE syndromes. You need the whole clinical picture.
Makes sense. Integrate everything. Yeah. Okay, let's talk treatment properly now. The therapeutic landscape. What are the mainstays?
Anti-seizure medications, ASMs, are definitely the primary therapy, still the cornerstone for IgE.
And choosing the right one depends on.
A whole bunch of things. What types of seizures do they have? Absence, myoclonic, tonic-clonic? What's the likely syndrome? How old are they? Any other health problems? What other meds are they on to avoid interactions? And hugely important, what are the potential side effects?
It's a balancing act.
Always. And while, as we said, many kids respond well initially, a lot of people, especially those with adolescent or adult onset like JME, often need treatment long-term, potentially lifelong, to stay seizure-free.
Though lifestyle management can sometimes help reduce the medication burden.
Yes, that's a point the article makes. Good sleep, managing stress, avoiding triggers. Sometimes that allows for lower doses or fewer meds, even if lifelong treatment is needed.
What have the big clinical trials told us about which ASMs work best in IGE?
Some key findings highlighted in the article. One big head-to-head trial found valproate was better than lamotrigine or topiramate in terms of how long people stayed on it and achieved remission.
Okay, valproate often comes up as very effective.
It is, but it has significant risks, especially for women, which we'll get to. For childhood absence epilepsy specifically, ethosuximide and valproate both beat lamotrigine. Ethosuximide is often preferred first because it tends to have fewer side effects than valproate.
Good to know. What about JME?
For JME, studies suggest valproate might give slightly better odds of complete seizure freedom, but again, lamotrigine is often better tolerated. Big caveat, though, lamotrigine can sometimes make myoclonic jerks worse in some people with IgE.
Oh, right. That's important. Need to watch out for that.
Definitely. Levetiracetam is another major player. It's FDA approved for JME and for generalized tonic-clonic seizures in IgE.
What about the sodium channel blockers like carbamazepine or phenytoin? They're common in focal epilepsy.
They can be tricky in IgE. They might actually worsen seizures, especially absence or myoclonic seizures in some people, particularly if the EEG shows lots of spikes together, Bali spikes.
So generally avoided unless it's just GTCS.
Often, yes. Newer drugs like lacosamide and perampanel seem effective for the GTCS component of IgE, but maybe not so much for the absence or myoclonic seizures.
Others.
The article mentions some anecdotal or smaller study evidence for drugs like brivaracetam, zonisamide, clobazam, clonazepam being potentially helpful in certain situations too. So there are options, but the choice needs careful consideration.
Absolutely. The article also flags specific challenges in certain groups, like teens and young adults.
Yes, we touched on it, but adherence can be a big issue, remembering to take meds regularly. Plus, the lifestyle factors, sleep deprivation is huge, alcohol use, stress.
Yeah.
They all lower the seizure threshold.
And they often cluster together in that age group.
They really do. It's a tough combination.
And for women of reproductive age, big considerations there too.
Huge. Firstly, some ASMs, particularly the older enzyme-inducing ones, can make hormonal contraceptives less effective. So risk of unplanned pregnancy.
Okay. Need reliable contraception advice.
Definitely. And then the issue of teratogenicity, the risk of birth defects if taking ASMs during pregnancy.
Which drugs are riskiest?
Valproate carries the highest risk of major malformations and is also linked to neurodevelopmental problems like lower IQ or autism traits in exposed children. Older drugs like phenobarbital, phenytoin, carbamazepine also have risks.
And safer options.
Levetiracetam and lamotrigine generally have the lowest reported risks among the commonly used drugs.
So the advice is,
Preconception counseling is absolutely vital. Discuss the risks and benefits of all options before pregnancy. Ensure adequate folic acid supplementation. Higher doses than standard are usually recommended. And the goal during pregnancy is always seizure control, with the lowest effective dose of the fewest possible ASMs, preferably avoiding valproate if at all possible.
it's a really complex decision-making process for women with IGE.
It requires careful planning and ongoing discussion. And we also need to consider excretion in breast milk, although most ASMs are considered relatively compatible with breastfeeding.
Okay. What about stopping medication later in life? We said JME often needs lifelong treatment. What about others?
Well, childhood absence has the best chance of successful withdrawal. Juvenile absence is somewhere in the middle. JME and epilepsy with GTCS alone have the highest risk of seizures coming back after stopping meds.
Are there predictors for relapse in JME?
Yes, things like starting meds at a younger age, not being seizure-free for very long before trying to stop, and needing polytherapy more than one drug to get control initially, those all suggest a higher chance of recurrence.
Right. Let's broaden out again to lifestyle and comorbidities.
Yeah.
These seem really integral to understanding IGE.
They absolutely are. Managing triggers is key. We mentioned sleep deprivation and alcohol, but also strong emotions, stress, sometimes even flashing lights, photosensitivity, or hyperventilation can set off seizures in IGE.
So identifying personal triggers is important.
Very. And strategies to manage stress, mindfulness, exercise, whatever works can potentially improve seizure control and definitely quality of life. We also need to be aware of the increased risk of alcohol use disorder in people with epilepsy generally.
And the cognitive and psychiatric side.
Yes, the executive function difficulties we mentioned, planning, attention, working memory, and the higher rates of anxiety, mood disorders, even autism spectrum traits. These aren't just side effects of seizures. They seem to be intrinsically linked to the underlying brain processes in IGE for many people.
A shared pathophysiology, perhaps.
Possibly. And the link with sleep is critical, too. Poor sleep can trigger seizures, and the epilepsy itself can mess up sleep architecture, creating a vicious cycle. Especially in JME, poor sleep quality is common.
And that ties back to the morning pattern of seizures, too.
Exactly, that matutinal pattern, myoclonic jerks, or GTCS often happening shortly after waking, it's all interconnected.
Okay, one final piece.
That's
Sudden, unexpected death in epilepsy. What's the key message for IGE?
The main thing to understand is that the risk isn't zero just because it's IGE. The rates seem comparable to focal epilepsy overall.
And the biggest risk factor is?
Uncontrolled or frequent generalized tonic-clonic seizures. That's the single biggest modifiable risk factor across the board.
But it can happen even if GTCS aren't that frequent.
Yes. And the article mentions an interesting, slightly concerning point. There might be an increased risk after a breakthrough GTCS, even in someone who is usually well controlled on medication. Perhaps more so than after a breakthrough focal seizure that doesn't generalize.
That underscores the importance of preventing those GTCS breakthrough seizures.
It really does.
Yeah.
Consistent medication, managing triggers.
Yeah.
It's all part of reducing SUTP risk, too.
Wow. Okay, this has been incredibly thorough. We've really dug into the complexities behind IGE. Just to kind of recap the big takeaways, especially for our listeners keen on neurology.
Go for it.
Right. So diagnosis isn't always simple. Watch out for that misleading asymmetry. The underlying brain mechanisms are still being uncovered. It's not just GABA and calcium channels. Seizure control can be tough, and many forms aren't just outgrown. The associated conditions, cognitive, psychiatric, are significant and need attention. And finally, treatment is evolving, with neuromodulation offering hope for drug-resistant cases.
That sums it up nicely. It really challenges the simpler view some might have.
It really does. And it leaves me thinking, given how common IGE is, but how relatively under-researched it seems to be, where should future research focus? What are the most promising paths forward?
That's the million-dollar question, isn't it? I mean, really digging deeper into that complex interplay, genetics, epigenetics, environment. How do they all fit together? Can we use that understanding to predict who will develop IGE or who will respond best to which treatment? That feels crucial for developing more personalized medicine.
Yeah, moving beyond the broad categories. And for the medical students listening, the message seems to be, look closely, listen carefully. These presentations can be nuanced. And remember, the comprehensive counseling aspect, It's not just about the seizures.
Absolutely. And for anyone really enthusiastic about the brain, maybe dig into some of the research cited in the Davinsky article or connect with patient advocacy groups. Hearing the lived experiences really adds another dimension to understanding IgE.
That's a great suggestion. It provides context beyond the clinical facts. So to wrap up, while there are definitely gaps in our knowledge, we do have effective tools and therapies. And by really focusing on those healthy behaviors, managing triggers, and tailoring the treatment plan carefully, we can make a real difference in outcomes for people living with IgE,
Mm.
improving seizure control, managing comorbidities, and hopefully reducing those serious risks like SUD.
Well said. It's about optimizing everything we can.
Indeed. Well, thank you for joining us for this deep dive.
My pleasure.